The following podcast is part of a certified educational activity titled Preparing Specialists for the New Era in Alzheimer's Disease, a case-based exploration of strategies for integrating diagnostic biomarkers and amyloid-targeting therapies into practice. Access the entire activity and complete the post-test at peerview.com/SRN860. Downloadable slides and practice aids are also available.
Welcome to this program, Preparing Specialists for the New Era in Alzheimer's Disease, a case-based exploration of strategies for integrating diagnostic biomarkers and amyloid-targeted therapies into clinical practice. I'm Dr. Sharon Cohen. I'm a behavioral neurologist and the medical director of Toronto Memory Program in Toronto, Canada. Our goals for today are to augment awareness of the rationale for identifying patients at risk for AD early in their disease course. Secondly, to enhance understanding of the relationships between specific AD biomarkers and the underlying neuropathological changes that define Alzheimer's disease and the clinical manifestations and severity of cognitive and functional decline. Thirdly, we want to increase the ability to employ validated biomarkers to make an accurate biological diagnosis of Alzheimer's disease in patients who present with cognitive complaints. And finally, we want to improve the ability to apply new and emerging disease-modifying AD therapies into customized treatment regimens for appropriate patients with early-stage AD. We all know that Alzheimer's disease is a growing healthcare need. The burden of Alzheimer's disease is tremendous. 60 to 80% of all cases of dementia are due to Alzheimer's disease, and over 10% of individuals aged 65 and older will have this disease. In 2024, 6.9 million Americans aged 65 and older are living with Alzheimer's disease, and the numbers are rising, such that by 2060, the number of people with Alzheimer's disease is projected to double to 13.8 million. Detecting Alzheimer's disease at the early stage is something that the Alzheimer's Association, CMS, and the American Academy of Neurology all recommend. Early diagnosis is important. However, in clinical practice, we're not doing so well with this, and recent estimates from several studies indicate that only 8 to 15% of individuals with MCI stage of Alzheimer's actually receive a diagnosis. 99% of primary care clinicians underdiagnose MCI. Validated imaging and fluid biomarkers are now available, but these are not routinely used in clinical practice. And we know, despite the fact that they're not being used, that biomarkers have been proven to change the management of patients at least 60% of the time when they are used. There are several steps in the diagnostic process for Alzheimer's disease. It generally starts with a complaint from a patient or family member. Something's wrong with my memory, or something's wrong with my word finding. I can't do things that I used to do. And then this complaint has to be explored further by a primary care practitioner. Often more history will be taken, blood tests will be performed, neurologic and physical exams should be done, and some cognitive testing, at least screening cognitive testing, should be performed, and an assessment of one's level of function. Structural brain imaging is also an important part of the diagnostic process. And once these elements are conducted, or at least in the works, referral to a specialist may be in order then to confirm the diagnosis with the use of AD biomarkers. Once you have a confirmed diagnosis, then treatment options may be in the hands of the specialist, particularly if they involve some of the new and emerging treatment modalities. Let's talk about navigating practical challenges in the diagnosis and management of Alzheimer's disease. We'll start with a case. We have a 76-year-old woman. She's got 18 years of education and a master's degree in English, and she's noted for the last 6 months that her memory is not as strong as it was, and she's also having trouble with word finding and misplacing objects. She also reports that she's mildly anxious, and in addition, she's withdrawn from doing some of her activities because she's lost interest in them. As far as her background health and family history, she has hypertension and type 2 diabetes, both controlled on medication. Her routine Blood work shows normal values, including normal TSH and B12. Her family history is negative for dementia, although her mother died young of breast cancer in her 60s. Father died of a stroke at 79. The primary care practitioner administered the Montreal Cognitive Assessment, or MoCA, and the score was borderline normal at 26 out of 30. However, the delayed recall for someone with a high level of education was 3 out of 5, which is not particularly normal. 3 out of 5 delayed word recall, and there was 1 error on serial subtractions as well. A mood screen, the PHQ-9, indicated mild symptoms of depression and anxiety. And our patient's husband indicated that, yes, she's independent in daily activities, including shopping, driving, taking her own medications. So we now have this initial presentation, and the primary care practitioner orders a structural brain image and refers the patient on, while waiting for that structural brain image to take place, refers the patient on to a specialty memory clinic. So the MRI scan in the specialist's hands shows mild to moderate bilateral parietal atrophy and mild bilateral hippocampal atrophy. There's also very minimal bilateral frontal atrophy, but the parietal hippocampal atrophy causes us to take note. There's mild to moderate small vessel ischemic change, which is not surprising or a cause for concern in a 76-year-old woman. There is, however, evidence of cortical infarction in the right cerebellum. The memory specialist meets with the patient and her husband and discusses the findings based on the medical history, the cognitive testing, the functional assessments, and the structural brain imaging. The conclusion is that this is an early stage of cognitive impairment. Individual is functionally independent, so we're dealing with mild cognitive impairment, and the suspected underlying diagnosis is Alzheimer's disease. So the next step would be referral to a specialist for biomarker testing to confirm whether Alzheimer's disease is the underlying cause. However, the patient declines further diagnostic testing. She says she's doing fine. She'd rather not receive biomarker confirmation that she has Alzheimer's disease because of the stigma associated and the fear associated with the diagnosis. How would you deal with this problem? There are many barriers that can prevent a timely diagnosis of MCI and mild dementia due to Alzheimer's disease. Some of these relate to healthcare providers and the healthcare system they work in, and others relate more to patients, their perceptions in the community at large. With respect to healthcare providers, they may have limited skill or lack of confidence to make a diagnosis of a complex disease like Alzheimer's disease. Some of them are also not convinced that they have much to offer, so they do not believe there's much value in pursuing a diagnosis of Alzheimer's disease. Wait lists can be long to see a specialist, and this might also be off-putting for a primary care practitioner who might be willing to go through the workup if they could then have specialist support. But if that's not forthcoming for many months, then again, there's some futility there. From the patient perspective, there may be a lack of awareness that there's a significant memory problem. That may be part of the disease itself, or it may be a misunderstanding that normal aging is associated with memory loss and that this isn't a disease presenting. Some individuals are, in fact, quite concerned that something's changed with their memory, and yet stigma holds them back. They don't want to be confronted with a diagnosis of Alzheimer's disease and the fact that they have challenges, multiple challenges to look forward to, including being a burden on their family. There may be poor patient engagement in the healthcare system, cultural factors, linguistic factors that also interfere with people coming forward and being properly assessed. It is, however, important that we overcome these challenges and diagnose the disease early. And why is that? Well, having a clear diagnosis does validate a patient's and family's concerns and gives clarity to what's going on and stops people from having to search month after month, year after year for some answer as to why their memory might be slipping. It also allows people to make decisions about what they want in their own care and planning ahead at a stage of the disease when they're still able to participate actively and direct their own care. Individuals can be empowered also to make lifestyle strategy changes, which can slow progression of their disease and also help them manage comorbidities. Individuals can have access to education and personalized support services, which again can improve quality of life for patient and family. And having a biomarker-confirmed diagnosis of Alzheimer's at an early stage is required for new and emerging disease-modifying treatments. So we don't want people to smolder along and miss the opportunity for treatment because we haven't diagnosed in the earliest stages. And for individuals who are not candidates for the new treatment opportunities, they may well have clinical trial opportunities. And there are many clinical trials at early stages of Alzheimer's, including at the prevention stages. Looking at lifestyles, there are a number of strategies to bolster brain health. And these include everything from staying cognitively engaged, staying physically active, addressing sleep issues so that people have restorative sleep, improving nutrition so that one is following a brain healthy diet, addressing vascular risk factors, diabetes, hypertension, and limiting alcohol intake and smoking cessation. All of these things together can substantially reduce the risk of dementia. And the Lancet Commission on Dementia has actually come out and said one might be able to reduce one's risk of dementia by 35 to 40% through lifestyle changes alone. We are also now in the era of disease-modifying therapies for Alzheimer's disease, with the first of these being launched with the FDA approval of aducanumab in June 2021. So aducanumab received accelerated pathway approval based on its lowering of amyloid in 2021. And then in January 2023, lecanemab received accelerated pathway approval. But 6 months later, July 2023, lecanemab received full traditional FDA approval for the treatment of early AD based on clinical data showing disease slowing. And most recently, donanemab has received full traditional FDA approval for the treatment of early AD. So that was July 2024. In the interim, the manufacturer of aducanumab has discontinued its production in order to focus on other projects. So let's go back to our 76-year-old woman. She's presenting with mild cognitive impairment, suspected to be due to Alzheimer's disease. She wasn't sure she wanted biomarker confirmation, but after discussing this with her care team, she thought, okay, I see the rationale for getting some diagnostic clarity. So she was referred to a specialist for biomarker testing to confirm or rule out Alzheimer's disease. And the question arises, which biomarker test should be ordered? So there are a number of factors to consider. What is the access? Does someone have access to a PET center, or is CSF testing through lumbar puncture available? What is the cost? Are there any contraindications from a safety standpoint? What is the sensitivity, specificity, reliability, and accuracy of the measure? And does it have FDA approval? Is it going to be standalone adequate to qualify someone for disease-modifying therapy such as lecanemab or donanemab? If we look at biomarkers in Alzheimer's disease, there are several. They become abnormal at different times, and there's a continuum that we can follow. So the ATN framework in 2018 described amyloid, tau, and neurodegeneration as the three major classifications of biomarkers, with anybody who was amyloid positive or A positive being on the Alzheimer's continuum. And the further one is on the Alzheimer's continuum, the more you start to see all of the biomarkers to be positive. So A positive, T positive, N positive. And if you look at the curves on your right, you see that the earliest biomarker change is amyloid in fluid, or CSF. So that's the first change that we can see, followed by amyloid on PET scan. The next change we see is in CSF. Phosphorylated tau becomes abnormal, and that is followed by abnormal tau PET signal. And finally, we see biomarkers of neurodegeneration, so MRI, medial temporal lobe atrophy, or FDG PET, hypoperfusion, or reduced glucose uptake. And these all precede cognitive impairment and functional decline. As of 2024, we have updated criteria for biomarker diagnosis and staging now of Alzheimer's disease. And AD biomarkers are divided into core 1 biomarkers for diagnosis, core 2 biomarkers for staging, and then there are biomarkers of non-specific processes involved in Alzheimer's disease, as well as biomarkers that are representative of non-Alzheimer's co-pathology. So if we look at a little bit more detail here, of the core 1 biomarkers, we have amyloid in fluid or imaging. We have T1 biomarkers, which represent phosphorylated and secreted AD tau. Then for the T2, core 2 biomarkers, we have biomarkers that represent AD tau proteinopathy. And in fluid, these are p-tau 205 or MTBR 243 or non-phosphorylated tau fragments, whereas with imaging, we have tau PET. And then the biomarkers that are non-specific but are part of the pathophysiology of Alzheimer's disease include the N for neurodegeneration, NFL, and medial temporal lobe atrophy, glucose hypoperfusion on PET. Inflammation is an interesting one, and GFAP is one of several inflammatory markers, but we can see this in the CSF. And although inflammation is not specific to Alzheimer's disease, it is absolutely one of the processes that complicate Alzheimer's pathophysiology. And finally, vascular change, and specifically ischemic change in the brain, ischemic stroke, is a non-Alzheimer's co-pathology. In elderly individuals, we often see evidence of some lacunar infarcts or other strokes. And then S stands for alpha-synuclein, and we have an alpha-synuclein assay in the CSF. And this is a biomarker for Lewy body disease or Parkinson's disease. If we focus on the core 1 biomarkers a little bit more, any of these core 1 biomarkers are satisfactory for a diagnosis of Alzheimer's disease. And you'll see that in the fluid biomarkers, it's the ratios of A beta 42 over 40 or p-tau 181 over A beta 42, et cetera, that are the preferred CSF biomarkers. The CSF biomarkers listed, as well as amyloid PET, are the ones in the red box that are FDA approved. Amyloid PET has actually been demonstrated through clinical pathologic, meaning clinical and autopsy confirmation of its accuracy in demonstrating amyloid plaque burden. And so we have 88 to 98% sensitivity, 80% to 95% specificity as a proxy for amyloid accumulation based on PET to autopsy studies. Amyloid starts accumulating up to 2 decades before onset of clinical symptoms. And we know that amyloid PET can improve early diagnosis and inform appropriate treatment management. And in the IDEA study, we saw that over 60% of individuals had a change in management when they had PET amyloid confirmation or refutation of the diagnosis of Alzheimer's disease. So knowing if you're amyloid positive makes a difference to management. By contrast, CSF has been validated in comparison to PET amyloid, not to autopsy. However, the concordance is about 90%. So this is considered very high. And the bottom line is that either CSF, AD biomarker, or amyloid PET can serve as the indicators that someone has Alzheimer's disease. So they can be used interchangeably, and one doesn't need to have both sets of biomarkers, CSF or PET, just one or the other for diagnosis. Of the plasma biomarkers, there have been a few papers recently that indicate that p-tau 217 actually outperforms the other plasma biomarkers for tau, particularly better performance than p-tau 181 and p-tau 231. And this better performance is not just in separating amyloid positive from amyloid negative individuals with mild cognitive impairment, but also separating out those who progress versus those who will be non-progressors. For each of the modalities of biomarkers, whether it's PET imaging, CSF, or plasma, there are advantages and limitations. For PET imaging, the main advantages are that we have 3 validated and approved, FDA-approved tracers for amyloid imaging and 1 for tau imaging. The cost is recently covered now for amyloid imaging by CMS, by Medicare. With amyloid imaging, you can have both a quantitative and a qualitative read, and you can see spatial distribution of amyloid. Where in the brain is the amyloid burden building up? But PET scans are expensive. They are not readily available in many geographies throughout North America and other parts of the world. So there's going to be limited access, there's going to be increased cost, and there's some radiation exposure that shouldn't be ignored. With CSF, we have a much more widely available technique now, lumbar puncture that can be performed by many different healthcare providers, and we have multiple FDA-approved tests. Also of note, with the CSF sample, one can measure multiple biomarkers. So with amyloid PET, you're just measuring plaque-bound amyloid. But with CSF, you can measure amyloid, you can measure tau species, GFAP for inflammation, and other markers. However, there is some reticence on the part of some practitioners and some patients to undergo a lumbar puncture. I think the invasive nature of the lumbar puncture has been exaggerated, and people are becoming more accustomed to the fact that this is a very reasonable procedure to perform, can be performed safely in the office. But not everybody can have a lumbar puncture. There may be some contraindications, particularly individuals who've had some spinal surgery in the past and may have spinal deformities, or individuals who cannot safely come off anticoagulant treatment for the duration of the lumbar puncture. As far as plasma, we feel that the plasma AD biomarkers have the ability to revolutionize the future. They will be minimally invasive, widely accessible. The costs will be lower than for CSF or PET. And what we're waiting for now is FDA approval and more normative data with validation across real-world populations. But we do have CLIA-certified plasma biomarkers, and I mentioned the p-tau 217 really being a high-performing biomarker. Here's a list really just for your reference of different commercially available biomarkers for Alzheimer's disease, what they measure, and whether they have FDA approval, CLIA approval, or other status. So let's go to a different case. 56-year-old woman presenting with mild dementia due to Alzheimer's disease. She's APOE4 homozygous. Is she eligible for treatment with amyloid-targeted therapies? Well, she has mild dementia, MMSE 22 out of 30. Her amyloid PET scan is positive. So we've got the right stage of disease, mild dementia, amyloid positive. She's an APOE4 homozygote with a strong family history of Alzheimer's disease. Her medical history and her pretreatment MRI don't show any exclusions to amyloid-targeted therapy. If we look at how these first disease-modifying therapies that have been approved work, we see that they target amyloid and can substantially reduce amyloid plaque. And some patients will be amyloid negative by PET imaging within 6 months. But the majority by 18 months of treatment, whether it's donanemab or lecanemab, will be amyloid plaque negative. We also see with both of these new treatments, consistent signals of downstream biomarker normalization. So improvements in tau levels, improvements in markers of neuroinflammation and possibly neurodegeneration. From the clinical perspective, what we see is slowing of clinical decline. both slowing of cognitive decline, functional decline, and less decline on health-related quality of life measures. And we see slowing of progression to the next stage of disease, so that individuals are saving time, on average 5 to 7 months over an 18-month period. So they have not reached the same levels of decline that people who were not on treatment reached 5 to 7 months earlier. In implementing the use of amyloid-targeted therapies, it's important that we select the right patients. So we need patients to be in that early AD stage, MCI or mild dementia. They need to have a positive AD biomarker for amyloid. We need to assess their background health, their risks, and then look at what their treatment goals might be. We also need to know that we have the facility and capability to roll out intravenous treatment at the frequency required for these drugs. So we need to set up the appropriate infusion centers, or partner with standalone infusion centers, and look after the various administrative aspects as well. Treatment monitoring is also very different from what it has traditionally been for Alzheimer's care in the past. Now we need to follow with scheduled and sometimes unscheduled MRIs to make sure that we are not getting into side effects of ARIA. We also need to look out for infusion-related reactions. So there are a number of different things that go into clinically implementing the use of amyloid-targeted therapies. Here's some practical tips. It's important that every site sets up their own protocol, because some challenges for some sites may be unique to that site. Others will be different. So we need each institution who's thinking about offering amyloid-targeted therapy to look at the protocols that will best suit their center. How are we going to assess for amyloid confirmation? Are we going to rely on PET imaging? Is it CSF who's going to do the lumbar punctures, or can we offer at any given institution an array of options? Some people will have LPs, some will go for PET scans. And then we need to think about, are we going to offer APOE genotyping? Because this will inform the risk-benefit discussion. How are we going to do this? Who's going to discuss the APOE results? If we're infusing people at standalone infusion centers, it's probably a good idea to visit those and make sure that there's a sense of shared responsibility for what happens to the patient at the infusion center, and who the infusion staff can contact, particularly the prescribing physician if there's any problem during the infusion. We also need to educate emergency physicians and primary care physicians about the possible risks of anti-amyloid therapy. In terms of financial burden and treatment, there may be many costs associated, and we leave that to each institution to work out. So in terms of selecting the right patients to treat with anti-amyloid monoclonal antibodies, the FDA prescribing information for lecanemab and donanemab need to be front and center here. Appropriate use recommendations have been drawn up for lecanemab. They are a little bit more restrictive than the FDA prescribing information, and we don't yet have appropriate use recommendations for donanemab. Basically, we're looking for individuals, as we've said, who are at the early symptomatic stage of Alzheimer's, MCI or mild dementia stage, with confirmed amyloid positivity on PET or CSF. And this could be operationalized to an MMSE of 20 to 30 or MoCA greater than 18, according to the AUR. But there's some notable exclusions, and it's important to get a pre-treatment MRI to make sure there are no contraindications. And what would those be? Greater than 4 microhemorrhages would be a contraindication. Any area of superficial siderosis, greater than 1 area of superficial siderosis, or significant cerebrovascular disease with severe white matter changes on MRI, macrohemorrhage, or greater than 2 lacunar infarcts, or a single infarct greater than 1 centimeter. The appropriate use recommendations also restrict anticoagulant use, although notably the FDA prescribing information does not. And then any individual who's unstable from a medical or psychiatric standpoint should probably be excluded from this kind of anti-amyloid therapy. ApoE genotyping is recommended for all patients. It's not mandated, but it is important in terms of providing additional information that would inform the benefit-risk discussions. The main risk of concern for anti-amyloid monoclonal antibody therapy is ARIA. And the risk factors for ARIA really rest with the amount of underlying cerebral amyloid angiopathy that a patient will have. The ApoE4 allele will, if present, increase the risk for CAA and ARIA, and especially in homozygotes. So the heterozygotes, one copy of ApoE4 increases the risk of ARIA a little bit, but more substantially if there are two copies. The dose of anti-amyloid targeted therapy also increases the risk. The higher the dose, the greater the risk. And of note, the risk for ARIA is greatest in the first few months of treatment, and then it's reduced after that. So there's the higher period of risk in the first 6 to 7 months. The risk of ARIA is related, as we've said, to ApoE4 genotype in a dose-dependent manner. So the higher the incidence of ARIA with the higher number of copies of ApoE4 allele, and a higher rate of recurrent ARIA as well. So informing patients of their ApoE genotype and having a conversation about what this means, might mean for their risk is important. And we haven't been in the habit of testing people for ApoE genotyping for treatment purposes. So this is something new that institutions or clinics who want to prescribe anti-amyloid monoclonal therapies are going to think about now. We have often thought about ApoE genotyping in the context of assessing risk for Alzheimer's, but that's not as relevant in this situation because we're not relying on the ApoE genotype to make a diagnosis. We need a biologically confirmed diagnosis with PET or CSF. So we don't need to spend a lot of our time talking about that in the context of starting anti-amyloid therapy, but we do want to review the increased risk, and it's dependent on which monoclonal antibody treatment is selected, the risk of ARIA, but regardless, it does increase based on ApoE4 copy number. There's also information that's transgenerational, meaning that if you are an ApoE4 homozygote, then your children have at least one copy of ApoE4, and that may or may not be information that people want to know and share with their family. But I think the bottom line that's very, very important is ApoE4 homozygotes can still receive these anti-amyloid monoclonal antibodies if they are willing to assume the risk and undergo the monitoring that's necessary. And there isn't evidence that they don't get the benefit from the drug. And the monitoring and management of ARIA is the same across all the ApoE genotypes. So shared decision-making is really the name of the game. We want to make sure that the goals and expectations of anti-amyloid therapy are understood clearly. And we are hoping to slow disease for any individual, keep them at the mild stage longer, prevent functional decline. We're not thinking that we can reverse cognitive decline that's already happened. This is not a cure that we have yet for Alzheimer's disease, but keeping mild patients mild is still very much valued, as long as that's what the patient and family understand is the goal of therapy. In terms of risks, we've talked about ARIA, so we describe this usually in terms of brain swelling or spots of bleeding, which often occur without any symptoms and resolve spontaneously for the most part. Patients need to commit to coming to infusion visits fairly frequently, so there's an increased burden over taking a pill daily, which has been the case for symptomatic treatments for Alzheimer's disease. There can be costs associated, And there can be infusion-related reactions, which usually are not a deal breaker, but still, we need to look out for these and sometimes pre-medicate for these. In terms of alternatives, there really aren't other alternative disease-modifying therapies yet on the market, but these will come. And some could be taken in conjunction with anti-amyloid therapy in the future, and others will be perhaps instead of these monoclonal antibodies. But any patient should have the advantage of being on treatment for mild dementia due to Alzheimer's disease. There are prescribable symptomatic treatments, lifestyle modifications they should be aware of, and clinical trials as well to improve their outcome and improve future interventions for all. So here we have a 79-year-old gentleman. He's presenting with mild dementia due to Alzheimer's disease. His baseline MRI indicates a high risk for ARIA. So is he eligible for amyloid-targeted treatment? His MMSE is 24, so it's within the range of mild dementia. His CSF biomarker testing is consistent with AD pathology, so he checks that box. He's an ApoE3/4 homozygote, so he's okay there. Again, it informs us he's at a little bit higher risk for ARIA being E4 heterozygote. He's on anticoagulants for atrial fibrillation. And his MRI shows that he has mild to moderate small vessel ischemic change, 5 microhemorrhages, 1 area of superficial siderosis, and 3 lacunar infarcts. The role of the MRI in the workup of mild cognitive impairment and Alzheimer's disease, mild dementia, is really crucial. The MRI serves as the structural brain image that gives us 3 different buckets of information. One is to rule out non-Alzheimer's causes of cognitive impairment. So ischemic stroke, mass lesions, tumors, cysts, abscesses, traumatic brain injury. So is there gliosis, previous subdurals? So non-Alzheimer's causes for the cognitive impairment the patient's presenting with. But secondly, the MRI can identify changes that are suggestive of or supportive of the diagnosis of Alzheimer's disease. These would be things like focal atrophy in the hippocampus, medial temporal lobe atrophy, or microbleeds, not with a history of brain trauma, and these are suggestive of underlying CAA, that is part of Alzheimer's disease. So while MRI is not a sufficient diagnostic biomarker for AD, these findings could be suggestive. And finally, the third bucket is MRI is needed if we want to determine eligibility for amyloid-targeted therapy. So in terms of a baseline MRI that needs to occur before one can be deemed eligible for amyloid-targeted therapy, some exclusions exist. And these are based on the trial population for Clarity AD, which was the lecanemab phase 3 early AD study, and the Trailblazer-ALZ 2, which is the phase 3 early AD study for donanemab. They're very similar, so I won't read through the whole table, but you'll get the gist of it. Anybody who has more than 4 microhemorrhages on a pre-treatment scan is not eligible. Anyone with a single macrohemorrhage or an area of superficial siderosis. So some discrepancy, is one area okay or no areas of superficial siderosis. Vasogenic edema, so if they already have ARIA-E, that would be a deal breaker. Multiple lacunar infarcts, particularly involving major vascular territory, and severe white matter disease or severe ischemic change. So you get the gist. They're very similar between the lecanemab and donanemab exclusion criteria on MRI. We have a 76-year-old woman. She's receiving biweekly amyloid-targeted therapy infusions for the treatment of Alzheimer's disease. And on a routinely scheduled monitoring MRI, we see mild ARIA-E. Can we continue treatment? So the MRI shows a small area of hyperintensity on flare sequence indicating mild ARIA-E, but the patient had no symptoms, so we would not have picked this up if the patient didn't go for her scheduled MRI. There is a scheduling scheme for both lecanemab and donanemab to ensure that we don't miss ARIA. Much of ARIA is asymptomatic, but we want to classify it radiologically as ARIA-E, ARIA-H, and the severity, so we can determine whether we need to hold doses or discontinue doses. So we need to identify an MRI facility that's going to be available to the patient, schedule routine safety MRIs up front. These can be scheduled at the same time as booking the infusions. And the scheme for lecanemab would be that after the baseline MRI, prior to initiating treatment, we need a safety MRI scheduled prior to the 5th, 7th, and 14th dose. And for donanemab, there's an extra one in there, a safety MRI prior to the 2nd, 3rd, 4th, and 7th dose. The AUR criteria suggests for lecanemab that maybe at the 12-month mark, so that's after the 26th dose, in selective patients, there might be an additional safety MRI. And then, separate from these scheduled MRIs, anybody who presents with a new headache or focal findings, symptoms that might represent ARIA, we need to make sure that we have access for them to an MRI, for an unscheduled MRI. How do we deal with mild asymptomatic ARIA? So it's mild radiologically, asymptomatic as far as the patient is concerned. And what we are able to do, and we understand from the trials that have already taken place, is that we can safely continue treatment and monitor with monthly MRIs. So now we're not reverting to the pre-scheduled treatment MRI schedule. We're saying, okay, we see small amount of ARIA-E, let's say, on a scheduled MRI. Patient has no symptoms or findings other than the MRI findings. So now we would schedule monthly MRIs to look for ARIA resolution. That's in the case of ARIA-E, or stabilization as in ARIA-H. ARIA-H leaves its mark on the MRI, so it doesn't actually resolve, but we don't want an increased size of ARIA-H or increased numbers, so we would consider it stabilized if there's no change at the next monthly MRI. We need to make sure patients are compliant with this schedule of monitoring and that they understand the reason for it. Some patients and clinicians might be more risk averse, and based on APOE genotype or other factors, they may want a little bit different, maybe more vigilant schedule, but it is monthly monitoring for mild asymptomatic ARIA. So although ARIA is generally asymptomatic, some patients will have symptoms, and whenever there are symptoms, the dose should be held. And these symptoms can be headache, confusion, dizziness, nausea, vomiting, fatigue, blurred vision, visual disturbance, gait disturbance, seizures. So a lot of non-specific symptoms, and given that headaches are so common, it can be difficult to know. So you really need to be in touch with the patient, determine whether there's a level of suspicion that this might be ARIA, and have the person scanned. In terms of what we see for ARIA-E and ARIA-H, ARIA-E stands for edema or effusion. So amyloid-related imaging abnormality, edema, when the swelling is within the brain parenchyma, or effusion when it's leptomeningeal, presence of increased fluid. For ARIA-H, we have microhemorrhages and superficial siderosis. And here we need different MRI sequences to see these. So with ARIA-E, we need T2 flare sequences, but for ARIA-H, we need GRE or T2 star, so rapid sequences to pick up blood. So microhemorrhages, superficial siderosis, and we basically have leaky blood vessels that are leaking either blood products or proteinaceous material into the brain parenchyma or on the sulci or leptomeningeal surfaces. In terms of characterizing ARIA radiographically, we have a scheme for severity. So we talked about asymptomatic mild ARIA and being able to continue dosing. And what is mild radiographic ARIA? Well, for ARIA-E, This is ARIA that's confined to one location in the brain, and its size is less than 5 centimeters. It becomes moderate if there's 2 or more areas of ARIA on the scan, or if any of these measure between 5 and 10 centimeters. And severe ARIA-E would mean the area of ARIA is greater than 10 centimeters, and there may be more than one site in the brain. For ARIA-H, it's a little bit different scheme to classify severity. So we count microhemorrhages, and we need our radiologist, our MRI reporting physician to tell us how many microbleeds. So if there are less than or equal to 4 new microbleeds since the baseline scan, that's considered mild. If there are between 5 and 9 new incident microbleeds, that's moderate. And severe would be greater than 10 new incident microbleeds. For superficial siderosis, it's a little easier to remember. 1 focal area is mild, 2 areas of superficial siderosis moderate, and more than 2 is considered severe. Here's a table that is very useful to have stashed away somewhere to reference. So here we have, based on whether there are symptoms or no symptoms, and the radiologic severity, mild, moderate, or severe, whether you continue dosing, suspend dosing, or discontinue dosing completely. So when there's severe ARIA, then we don't go further. We discontinue dosing. In other cases, we may either continue if it's mild and asymptomatic, or if there are any symptoms, we would wait till symptoms resolve. And if there's moderate ARIA, again, we would suspend dosing. But the few areas that involve discontinuing dosing completely are important to note. So any radiographically severe ARIA-H, we need to discontinue dosing. And any severe symptoms, we would discontinue dosing. Many patients can resume treatment after resolution of ARIA. And so we need to make sure that we've followed the radiologic picture and the symptoms, and that both have resolved before restarting an amyloid-targeted therapy. We need to make sure that we've had a discussion of risk-benefit, make sure the patient wants to restart, although we've seen in our clinical trial program that most patients are eager to restart once ARIA resolves. And then we need to make sure that we revert back to scheduled MRI and take into consideration any other factors such as the patient's APOE genotype and other comorbidities. Let's direct our attention to a 68-year-old gentleman receiving biweekly amyloid-targeted infusions for treatment of Alzheimer's disease. He developed severe focal neurologic symptoms. What do we do? So he's being treated with an amyloid-targeted therapy. He called his memory specialist to report neurologic symptoms, which included confusion, headache, aphasia, unsteadiness. So the management of severe neurologic symptoms in people treated with amyloid-targeted therapy really involves getting an urgent MRI to clarify whether this is ARIA or something else. So if someone has acute confusion, that could be ARIA, but they could have had a thalamic stroke or something unrelated. So we need an MRI. A CAT scan won't do it because a CAT scan cannot differentiate ARIA-E, ARIA-H. It cannot detect them adequately. So we often have to make a decision whether to send the patient to the emergency room, depending on the severity and acuity of their symptoms, and weigh the risks and benefits of sending a patient to the emergency department. What we don't want to happen is for a patient to go to the emergency department, undergo a CAT scan, be misdiagnosed possibly as having an ischemic stroke as the explanation for their symptoms, and then get treated with a thrombolytic agent for stroke, when in fact an MRI scan might have shown this patient has ARIA, and thrombolysis is not the treatment for ARIA. So this is where the caution comes in, but of course going to the emergency department may get you an urgent MRI scan, which would be appropriate, and the level of care that you may need. So one has to be mindful that this is a new paradigm for many clinicians. So we need to be able to share information with our colleagues in the emergency room. And it's very helpful for a patient who shows up with symptoms to have an arm bracelet or a wallet card or something that indicates they're being treated with an amyloid targeting agent for early stage Alzheimer's disease, because we can't assume that the emergency medicine team in the ER knows about these therapies. Um, if there are underlying comorbidities or previous MRI evidence of CAA, that may be helpful to share with them. Whether they've had previous episodes of ARIA, again, that may be worth sharing with them. And of course, the overarching concern is that ARIA can mimic a stroke, but TPA can be deadly in patients with ARIA. So we really need an MRI scan with the appropriate sequences, the FLAIR image to sequences to rule out ARIA-E and the T2 star and GRE sequences for ARIA-H. So here's a table that, again, captures some of the things we've talked about, and it's really for reference. But if we're worried about suspected severe ARIA, a strategic plan is helpful. And one should think about this even in advance of having to deal with any of these events. Can we educate our emergency room colleagues? Can we make sure that MRIs are available on an emergency basis with the right sequences? And will the radiologist be able to be in contact with the treating neurologist so that there is an exchange of information, rapid communication about how best to manage a patient should ARIA be found? Should the anti-amyloid antibody therapy be held? It's going to, again, depend on what's found. If there's ARIA and it's symptomatic, absolutely, it needs to be held. And then patients, rarely with severe ARIA can require hospital admission and careful monitoring and management. Sometimes they are treated with steroids. Different institutions may have different protocols. IV methylprednisolone is the one that has received the most attention. And usually it's a short course for 5 days with a tapering dose or oral taper. And most patients recover, but they do need the high level of care initially if they have severe ARIA, and there needs to be vigilance for the possibility of seizures as well. So we have a 68-year-old gentleman receiving biweekly amyloid-targeted therapy infusions since August 2023. He had to discontinue treatment after experiencing severe ARIA, and that was in May 2024. So he had almost a year of treatment, and then he had to permanently discontinue. What do we do next? His MoCA score, fortunately, has declined only 1 point from baseline, so he stayed fairly stable, still in this mild cognitive impairment range of scores. And what treatment options are available for him now? Well, many of the treatments that hopefully he already had access to, non-pharmacologic treatments, at the time that he was being treated with a monoclonal antibody are still relevant. So if he hadn't already been referred to support groups and been in touch with social workers or the local Alzheimer's Society chapters, that would be helpful. He should have the benefit of community resources and community services and counseling on the importance of lifestyle factors to build up brain reserve, whether these are dietary factors, physical exercise, or social and cognitive engagement, managing his overall health. So the kinds of things that we would do to optimize any patient with early stage Alzheimer's disease, these are still important even if one has to discontinue their amyloid targeted therapy. If he has mild dementia, then a cholinesterase inhibitor should be initiated. If he's still at the MCI stage, then the cholinesterase inhibitors are not indicated for that stage of disease. Memantine would be appropriate for individuals with moderate to severe Alzheimer's dementia. There may be clinical trial options with investigational drugs that are not monoclonal antibodies and don't pose the same risk of ARIA. So that may also be something to explore for an individual who has to come off anti-amyloid therapy. As we can see, it is complex to manage patients with monoclonal antibodies targeting amyloid, although it's doable. In my view, it's rewarding and it's moving the field forward and offering patients something they haven't had a chance to have before, slowing down their disease at a mild stage. However, we need to draw on multiple team members, including social workers, care planners, nurses, perhaps nurse practitioners, psychiatrists, neuropsychologists, geriatricians. Let's see how we can all work together. And we've mentioned the emergency department staff also. We need to get people communicating in a new way about risks and benefits of therapy and what's involved. So in conclusion, amyloid-targeted therapies represent an exciting advance in care for patients with Alzheimer's disease. Clinical diagnosis at the mild cognitive impairment and mild dementia stage is needed for amyloid-targeted therapy eligibility. Biomarker confirmation of AD is also necessary to take advantage of amyloid-targeted therapies. Patients need to be selected carefully and monitored carefully, and that's critical to the success in utilizing these new therapies. Benefits and risks of amyloid-targeted therapy should be discussed with patients and families, and care teams with appropriate infrastructure and communication are needed for the successful rollout of amyloid-targeted therapies and ARIA monitoring and management. Thank you so much for joining us today.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/SRN860.